Well, thank you to those that have been able to join us live today. So exciting. So I might just launch in and then we can get straight into the guts of it all. So welcome everybody. Before we get started, and in the spirit of reconciliation, Belongside Families acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. My name is Pam, and I'm joining you today from the land of the Ngunnawal people. So, welcome to our medical information series. Oh, I love this series. It brings me so much joy to bring all of these incredible people who just have so much information to share with all of you. And just really build community around our medical families. It's so important. So today we're going to hear from Natalie from Children's Nursing Queensland. She's a clinical nurse consultant and registered stonewall therapist with extensive experience in supporting children with complex needs. This is the second time she's sharing her knowledge with us, and I'm so excited to welcome her back. But just very quickly, before I hand over to her, I'm going to cover some important housekeeping just to make sure that you can get the most out of today's session. So today's session is going to run for approximately 20 minutes to half an hour. Really short, sharp. We're into it today. Super excited. So this session is being recorded. So at the end of the session, we'll collate all of the information and everyone will receive a link to the recording within the next couple of business days. You'll have access to the replay for the session for 30 days, I believe, and the presentation slides that Natalie is sharing with you today will also be attached to that email, so you'll be able to get all of the information and details that you see today. To ensure that it's a beautiful, smooth experience for everyone. If you've got any technical issues or need some support with any of that, please use the chat function. If you've got any questions about the content or have questions for Natalie, please use the Q&A box. So they're right next door to each other on the little toolbar down the bottom of your screen. So we'll address the questions during the designated question and answer box at the end, provided there's enough time for us to. So if we don't get to all the questions, I'm really sorry. But hopefully some of the information that Natalie shares with you today answers a lot of your questions. And just very quickly and really importantly, and a little note about privacy. As we've mentioned, this session is being recorded for future viewing. So please be mindful of this when you're asking questions or engaging in the chat. And please refrain from taking screenshots or making your own recordings without permission. You will receive everything that we share with you here today in an email in the next couple of days. So I'm going to hand over to Natalie. Welcome back.
Thanks for having us. We love doing this. It's a really good opportunity for us to also learn from other people. I think as clinicians where, we find out a lot of information about clinical things, but often it's the families who really teach us a lot about sort of stuff that really happens in the community, and we find out a lot. So hopefully this answers all your questions. I will say off the bat, I can talk underwater, so it's a real challenge for me to keep these short and snappy. So if you've got any questions, please send them through. I'm also going to try my absolute hardest to stay on track, but feel free to nudge me if I'm taking a bit too long. I guess to sort of get started, is it going to work? There we go. Just to say who we are. So super quickly, we're a team of nurses and stonewall therapists, and we have a lot of experience in different areas. But somebody once called us the pee, poo, pus and peg nurses, and I think that's a pretty good summary of what we do. It's not the most glamorous position, some may say, but we absolutely love it because it's a really important part that really makes a really big difference to the quality of life for a lot of the people that we support. And there's a lovely photo of me recently with my colleague at the Poo Museum down in Hobart. So super quickly, we're going to talk about lots of feed-in tubes today. We're not going to cover them all, and it's really going to be a little snippet of each of these things. So without knowing what everybody has, I think it's a good idea just to really start off strong and say what feed-in tubes are to begin with. So gastrostomy is the term most of us have heard, and gastrostomy basically is a feed-in tube that goes into a hole in the stomach. So you hear of lots of different kinds of stomies or stomas. Stoma just means the surgically made opening, and so we can have stomas in our trachea to help us breathe, like a tracheostomy, or we can have stomas in our colon to help us poo. They're called colostomies. So gastric meaning stomach, stomy, gastrostomy. So we have these lovely little holes that are made by our surgeons, and then inside of those holes we need to have a feed-in tube to keep that hole open. So when we talk about feed-in tubes, that's what sits inside the gastrostomy. And we use that as a way to deliver food or medications or formula directly into the stomach and bypass the rest of the gastrointestinal tract. Lots of reasons why people may need them, ranging from all sorts of age spans and all sorts of kind of clinical reasons why. The most common that you hear is that people have a peg. We hear this all the time, and not everybody has a peg, but I feel like this is something that's terribly done in medical land when we're talking about these things. So I'm very passionate about the right terminology. So buttons and pegs. So they describe different procedures and different ways that they're made. So it's really important that you know what kind of feed-in tube your child has. Gastrostomies are surgically made, or laparoscopic gastrostomy is made by the child going to sleep, and they use a laparoscopic approach. So they pop 2 little holes in the tummy, blow the tummy up with some gas and find where that stomach is. And then they stitch basically a feed-in tube like this one into the stomach and stitch it in, and that's called a gastrostomy. It's one way of doing it, and in Queensland it's the most common. The other way is a peg, which is more of a pull approach, where that child goes to sleep and they have a rather large feed-in tube device go through the stomach all the way down, and through the mouth all the way down and then out the stomach, and they pull that device out. And that's called a peg. And it basically means it's inserted percutaneously and endoscopically. So buttons and pegs, really important first take home of the day, that you know which one that your child has, because the care of them can be really different, especially in the post-operative phase. Some other ones you might see, there's jejunostomies, which feed in the jejunum, which is further down in the gastrointestinal tract. There's gastrojejunostomies, which you can see here in a picture. These ones sort of let us feed into the stomach. They let us give medications into the stomach or vent the stomach, but feed further down. So not as common, but again, the care of these is really different. We have nasogastric tubes. So these ones are ones that go inside the nose, and they basically go all the way down and they feed directly into the stomach. Then we have other ones you might hear like transpyloric tube or transanastomotic tube. They're normally done further after surgery. So lots of different feed-in tubes. And we're going to talk about some of the issues today. So off the back, there's going to be some photos here. I feel like as medical parents, most of you are probably all familiar with photos, and they can be a really good example to kind of demonstrate some of the things we talk about today. We're going to talk about a couple of tidbits, just some quick snappy take-homes that you can have. These are the common issues that we have with feed-in tubes, probably the most common that we see. So leaking, tubes being too big or too small, skin breaking down, tubes coming out when they're not meant to, and knowing where to go to for help. So we'll focus on those today. These are some of the pictures of what tubes can look like when they're not ideal, when things aren't going well. And this is something that I would say most of our tube feed-in families experience. And they can often be easily fixed if we know how to fix them early and kind of provide that support as best as we can. So the first thing is leaking. You've got a hole that goes into the stomach, and your stomach makes acid to break down food. So when these devices leak, pretty often you're going to find that that leak is going to cause some excoriation around that skin, and it's going to be pretty painful to manage. So we often say it's a little bit like nappy rash with how it feels for people who experience this. It's a problem because it can be painful and cause discomfort, but also if you're leaking out copious amounts of feed, you can be malnourished or dehydrated, and you might be at risk as well of not absorbing your medication. So for our clients that have feed-in tubes and need seizure medications, this is really important too, because they're quite small doses, and if that leaks out, they're not going to get their seizure meds. Lots of ways we can fix it though. Most of our devices are balloon devices, and so you can see some pictures there of what they look like, different kind of balloons. Sometimes we can increase that balloon volume and it will create a tighter seal, so the leaking is not as likely to happen. And that's normally a really easy fix that we can talk parents through themselves. Sometimes you've got a faulty device. happens, or the device is old and we need a whole new device, which again, unless you're in that kind of post-op acute phase, we can generally teach families how to do this themselves at home, and it's normally a nice, easy fix. Normally, these devices need replacing around every kind of 6 to 12 months, but some of our clients might be even sooner. The other thing is it can be an easy fix if there's an acute reason why it's leaking. So anything that kind of causes more pressure, like vomiting, constipation, lots of coughing, if you think about those big tummy muscles you use, if they're doing that and they stop doing that, so if we fix the reason they're vomiting or they get better from their gastro bug they've had, typically that leaking will be fixed. And we manage the skin, like I said, a bit like nappy rash. So thinking, giving it a good clean, popping on a barrier, that kind of stuff really helps. Other issues, sizing. So children grow, we all know that. Children obviously grow up and they grow out, but some of our children as well who might have things like scoliosis or kyphosis can have positioning that makes sizing these devices a little bit challenging. If we have a device that's too big or too small, the issues that we see commonly is that they're uncomfortable and leaky. If they're too tight, they can cause some skin breakdown, which we call a pressure injury, and it can increase the risk of the tube coming out, which is what nobody wants. And so there's lots of ways that we try and support people to fix that. The very first is that we can typically make the balloon bigger in these feed-in devices, and that will give you a tighter seal around the gastrostomy. So it's a very little example here, a little feed-in tube here. The more that we put in these balloons here, the tighter the seal. The less we have, the looser the seal. And most of the time, we've got a bit of wiggle room with how much we can go up and down with those. Sometimes, though, we do need to resize these devices, and there's a picture on the screen there of what those devices look like when we resize. And that's normally done in a clinical setting or having a specialist come out to your home to do it. It's not something families normally do, but it's done in a very similar way as changing our buttons. The other thing is to think about weight and body shapes. So we know that if children are going to be changing their body shape, like if they have a spinal fusion, for example, then typically that's a good time to do a resize and make sure it's all on track. Tubes coming out. So tubes do come out, unfortunately. Children play, children move. Tubes are made of plastic. Lots of reasons why they're going to come out. So it's a problem because if they come out and you have nothing in the hole, just like getting a new piercing, you're at risk of that hole kind of closing over and not being able to put anything in there, and then you can't feed your child. So the idea is to try and get something in quickly so that that hole doesn't close. The other issue is it leaks. Obviously, that's going to be not ideal. It can be a bit messy, but also those issues with malnutrition and dehydration. And it's scary. Every parent, when you provide an education about these feeding tubes, says, what do I do when they come out? And they always have this sort of wide-eyed look of fear on their face. And it is scary, and we acknowledge that, but also a good stomal therapist or a good gastro nurse is going to teach you how to manage that really well. And you should feel really well supported with a management plan before you even leave the hospital, wondering what to do if that happens. So some photos there of what they look like when they come out. They sort of look like a little belly button. So their guts aren't going to fall out or anything like that, but they can be a bit scary and a bit intimidating to look at for the first time. So first things first, if you know how to change it, then you would put it back in. And typically that involves deflating that balloon device, one of these, taking it out and getting a new packet and putting it back in and inflating the balloon. That's a balloon device. It's different for every feeding tube, of course. But the idea is also just to get something in the hole. So if you haven't been taught how to change it, consider asking your surgeon or your gastroenterologist or your nurse if it's appropriate to use stoma stoppers, which you can see in a picture there, to pop inside the hole. They look like cute little golf tees, but they're super, super flexible. You're not going to make any holes with one of these ones. And they're just designed to fit that hole perfectly and keep that hole open until a feeding tube can be properly placed in. So most of our families have a pack of these in the glove box, pack at school, pack at home, pack at grandma's house. They're about $8 and they're a nice little way of providing that little bit of reassurance and peace of mind. If they are a new gastrostomy, then obviously there's some changes there with how we'd manage it. And typically it involves replacing the tube, and then they'd normally do a little bit of imaging with some contrast study just to make sure it's in the right spot. That's typically within the first 6 months, but after that, not so much of a worry. Where to go to from help. Also, a really big thing as well. We support a lot of people in the community and a lot of people in that kind of post-acute phase. And I think families feel like sometimes when they go and have these done in a hospital setting, they leave and they don't actually know where to go to for help. And they end up in sort of this void of Facebook groups and, social media and all of that kind of thing, which are not necessarily a bad thing, but you've got to use them cautiously and make sure that you know that your feed-in tube might be different to how their child had their feed-in tube done, even though they look the same. So my biggest thing is before you leave the hospital, you need to actually ask, where do I go to from here? If this comes out on a Saturday, who do I contact? If this comes out at 3 a.m., who do I contact? If I want to go overseas, who do I contact? Because that's the reality and that's life, is that feed-in tubes and problems never happen when all of your clinical staff are around. They come, always after hours. So please ask before you leave. If you are planning on moving house, think about the referrals that you need. So particularly in some of our bigger cities, if you transfer out of that catchment, they may want you to go to your local hospital healthcare service. And so it's worth asking those questions before you move and before that becomes an issue, to make sure that you've got that continuity of care and you always know where to go to. Think about beyond the hospital. So a big part of our role is going into daycares or schools or supported living environments and providing education to people who are not medical to know what to do with these tubes when things go wrong. And I think people don't often ask those questions in a hospital setting because you just don't have time to process and even think about life in the next 6 weeks. You're busy focusing on the here and now. But have a think about daycare, particularly, if you've got a little one, you're going to send them to daycare, how are they going to be supported there? Do you need some kind of educational workshops for those daycare providers? Do you need a letter from your doctor saying it's safe for them to return with a feeding tube? What's your management plan as a parent going to be when they return there? And I think engaging community providers, there's lots of us out there, and I think that's a big thing that can make life a lot more easy for you. You don't always need to go to a hospital to have these feeding tubes looked after. You can have it done at home via telehealth or at a community provider, which means you're not having that anxiety of going to find a car park and missing school or work and all of the other sort of anxieties of being in a hospital setting. It's everybody's right for support and right for information. So I think this is a really important one that a lot of families just don't have the capacity at that time to think about. And guys, that's me. I managed to keep it under time today, Pam.
You did
I
so
feel
well.
like it's super quick. And I think, if I had endless time to talk about feeding tubes, I would be here for hours because there's just so many things that kind of come up with them. So hopefully that just gives you a little bit of food for thought about where to look at getting those questions from. Yeah.
Amazing. Thank you so much. It's
No
always so
worries.
informative hearing your expertise. Does anyone have any questions that they wanted to pop into the question and answer box? And while I'm waiting for you to gather your thoughts and pop those questions in, Nat, if we were to put together a really simple, like, emergency kit, what would you recommend needed to be in that?
Love this question. I think assuming that their child has a feeding device that goes into the stomach, so it might be a bit different from a nasal one. We'll start with the stomach one first. A pack of those stoma stoppers I think is super useful to have because it just gives you options if things go wrong. Lubricant, so you can buy any sort of lubricant that you get from Coles or the chemist, basic KY, but from some of the kind of medical supply companies as well. You can buy these little like sachets of lubricant. They're like 40 cents. If you can, a syringe. So these are what we call slip tip syringes, and the edges of these fit into the balloon device on those feeding tubes. The reason for that is sometimes these tubes come out with the balloon intact, scarily, and so you might need to deflate the balloon before you put it back in. Apart from that, I would always have just a piece of paper with the kind of feeding tube that child has. And if you don't know, contact your doctor, or when you change your device, you'll get a little sticker. It's my little demo box here, but you'll get a little sticker that comes in the pack, and that'll tell you exactly the kind of feeding tube your child has. So make sure you've got that handy as well. And then if it needs replacement and you're not able to be contacted, ambos or doctors or nurses know what it is.
Beautiful.
Yeah.
Love that. Thank you. And there was another question that I had. Um, so you mentioned like getting daycare and school and various other caregivers on board. What's the best way to go about that? Is that just us relaying information that we've been given? Is there services available that do that?
Talking more to Queensland, just I guess we have more Queensland people here. Typically, you can go straight to your daycare and they will find someone within their inclusion support that has access to that. And they can fund that through inclusion support wherever you are in the country. You don't necessarily need to use your NDIS funds. They'll then be able to find someone who meets their criteria from an organisational perspective and be able to put it into place. Otherwise, you can contact your service providers. So, for example, we have people contact us directly and we'll contact the daycare on their behalf and arrange it all for them as well. I think it's dependent. Schools often will have their own nursing supports if they're a special school or if they're a mainstream school, whereas sometimes private schools will engage services like us if they don't have those nursing supports available.
Yeah, amazing. And finally, just very quickly before we go, if we do have a tubie at home, what are some of the signs we should watch for that could indicate that there's some kind of complication going on with their tube?
The tricky thing is there's no clear, concise answer, and none of us have X-ray vision, which is a really frustrating thing when you're explaining this to families because you can't give them the answer that they would love. Typically, these devices normally work pretty well, but there is something called buried bumper syndrome, which means that the little balloon, instead of sitting in the stomach, sits a little bit further out of the stomach. And if you go ahead and you feed into it, then all of a sudden your child's not getting feed in the stomach. It's very rare. Well, it's quite rare, but when it does happen, it's a medical emergency. And so we talk to families that if you go to give a feed and your child who was tolerating it fine all of a sudden is not tolerating their feeds, they're vomiting, they're complaining it hurts. Or if you look at the tube and it's really tight, so you can't kind of wiggle it at all, you can see some visible swelling or visible redness, I would not give the feed and just go to emergency. And they'll be able to confirm with placement, which is just a little bit of contrast that goes through. So they'll be able to confirm placement with a bit of contrast that goes through if it's in the right spot or not. And I think that's often a good way to start, but you'll get a feel for most of the time with your kids what feels like their baseline and what they'll, tolerate and what they won't. Yeah,
Yeah,
apart from
beautiful.
that, same signs of infection, so fevers, redness, swelling,
Yeah,
increased pain, that sort of thing. Yeah.
amazing. We've just had one little question come through. What cream or ointment have you found is the most effective to aid skin healing?
So, great questions. I think when we look at skin healing, if it's from a leak and it's just red and sore, the first thing is to fix the leak. So, we fix that first, so we're not going to continue to have sore skin. Short of that, cleaning it like you would in a normal bath or shower. Don't be scared to give it a good clean because sometimes people get really funny around it. Give it a good proper clean, a good dry, and then a barrier cream. So something I think probably most of our families use would be pseudo cream. I think just because it's got a really high zinc content. Really thin layer. If you can see white, you've put on too much. Do a thin layer a few times a day so you're keeping that the leak off of the skin, and typically you'll see an improvement within around 24 to 48 hours. And if not, then seek a medical review and they can bring out the big guns if they need to as far as products and stuff.
Beautiful.
Yeah.
Thank you so much.
Thanks for having us.
It's been such a great session, always so informative. So thank you for
Thank you.
always sharing your valuable insights. It's so appreciated. Your presentations are always so enlightening and very engaging and just full of really critical information that I know our families are going to just lap up. So thank you. And thank you to all of the participants who have attended live today. I really appreciate it. Um, I hope you found it beneficial, but your engagement is what makes these sessions so incredible, and we really do appreciate it. So thank you. So as mentioned at the start of the session, you'll all receive an email that has a link to today's session. Natalie has very kindly shared the slides with us, so you'll receive a copy of her slideshow as well. Um, And you'll have, I'll pop Natalie's contact details and everything in that email as well. So if you have any further questions that are very specific to your individual circumstances, I'm sure she's very happy to help you guys out. And as always, jump into the Belongside Families community, continue the conversation. Let's keep chatting and like letting people know that we're not alone in all of this. So you know where to find us: Facebook, Instagram, everywhere. If you're not already, please sign up to the newsletter so that we can continue sharing all of the webinars and events that we have happening this term. There's so many, and I'm so excited. So please, if you get an opportunity, check out our events page on our website. There's so many incredible things happening this term, specifically after the diagnosis. There's a 4-part series where we explore just what next. You've been chasing that thing for so long, and now suddenly we're there, and like, what now? So excited about that. We've got some really incredible speakers to coming to that. We've also got a series for siblings, which is really interesting and I'm really excited about. Um, and then in a few weeks, we've got Natalie back talking about preparing for puberty, which is a really intimidating topic, but I think it's also very relevant to a lot of us because our kids just keep growing, and rudely they're getting very close to needing to prepare for that. So if you haven't already, jump onto the website and register for those. They're all going to be fantastic. Thank you again for joining us. Thank you again, Natalie. I always appreciate your time. It's always so enlightening. I hope you all enjoy the rest of your day. Have a wonderful week, and I look forward to seeing you all really soon. Thanks so much.
See ya.